Thank you, Karen, for the nice introduction. And I do not pretend that I will tell everyone what is the new normal, but I think it's more a reflection of what we went through, every one of us in the previous 8 and 9 months. And also, if I can refer to the advisory board discussion we had yesterday evening, we already mentioned a number of issues as the consequence of the COVID-19 pandemic in our work, in our daily work, and also in our research. So briefly, and I will try to stay within my 20 minutes, what is a new normal? I think we all were used to use public transport in this way before COVID-19 situation. And the question remains, of course, whether we will continue to do that after the control of the COVID-19 pandemic. And I assume that most of us will say, no, it will be perhaps in a different way. If I visited the website from the ECDC and the World Health Organization yesterday evening, well, we are talking about an infectious disease with a global spread. Of course, depending on the testing policy, depending on the epidemiology, on the measures taken, also depending on the reporting system, we see this kind of distribution with a very or a higher endemicity clearly in the Americas and in the WHO European region, also some parts of Northern Africa. We are talking about a disease that represents more than 51 million confirmed cases as of November 11, and more than 1.27 million deaths for the moment, and indeed representing quite a lot of disease activity in the Americas and in Europe, with all the consequences that we have experienced so far. Now, what will be the new normal? And I just highlight a number of things, different rules and measures per continent and country, and those living in the EU will, of course, experience that the countries in the EU seem to have different measures and sometimes are at different moments of the epidemic, which is not easy, of course, to try to inform people to control movement of populations over the border as long as the borders are open. And we have all experienced recently the situation where sometimes some shops are closed in one country and then people cross the border to go and shopping to another country. Maybe the same might happen with the medical shopping in the future. And I don't know whether that is a good way of working. So travel restrictions are now again on the agenda at EU level. Because we know that traveling might, of course, easily be a cause of transmission and cause of spread of the virus. Do we have to go for same measures per country, per continent is a question that is also on some political agendas. What kind of measures, and of course also the geopolitical influences that we all experience for the moment. Just try to order a -80 freezer, it's not evident anymore nowadays. So distribution of lab material, but also in the future, the distribution of the vaccines might be part of a geopolitical game. Looking at the situation in Europe, also that is from last night, showing indeed quite a patchwork of endemicity. We know, of course, this is related to test policy, this is related to the measures in different countries. But increasingly, I must say that countries are looking at Germany to well understand how to try to manage the second wave and to avoid a third wave. So the first message, and we all know that message, let's flatten the curve, shown here in a nice cartoon, but that was the first objective after the first wave, with very often a lockdown situation in many countries to try to control the pressure on the hospitals, the pressure on the intensive care units, and particularly also on the manpower working in the hospitals. We all know also this graph, I assume, where you can try to manage the first wave with the hammer policy and indeed use a lot of very strong and tough measures like lockdown and many other measures to try to bring the epidemic back to a situation where you can start to relax measures, but still try to control the number of infections a day, and in particular also the number of hospitalizations and admissions to the intensive care. And some countries are doing that in a better way, more adequate way than other countries. And that's more the face of the dance, where you start to see some countries entering in a kind of yo-yo system and having or experiencing a second wave and having to go to another lockdown or a lockdown that is defined in a different way. But that is putting a lot of pressure on psychologically, medically, also professionally, on, of course, the whole society. Just to mention a number of countries, and I take here the example of the calculations that were made in our country, in Belgium, where you see that homework and forcing people to stay at home and to do teleworking has at 40% has a larger impact than closing schools, for instance, on the epidemic. So that's quite interesting to look at also these different measures. So flatten the curve was the message at the first wave. Second wave, we hear much more crush the curve. So try really to bring it back to a number of infections or number of cases per day that is feasible, absorbable for the society. And you see different parameters that are being used now in the different countries, going from the number of cases per day, the incidence of cases per 14 days per 100,000, which makes, of course, comparison feasible, trying to get the reproduction rate under 1 and sometimes under 0.9, 0.8, depending on the country. Looking at the test positivity and also try to keep that as low as possible. And then you see countries trying to draw a policy according to the number of beds and manpower, which of course is rather risky, or rather a policy to try to control the epidemic. Understanding the epidemiology of an infectious disease seems to be not evident for policymakers. I think we have all experienced frustrations in our respective countries, looking at the exponential growth and very often at the late timing of measures. And it's clear, and we try to bring that across, that some measures will work better if you perform them or if you have them in the beginning of the epidemic than the same kind of measures once the epidemic is further going the exponential growth. So that's something where all of us have been confronted with when discussing or advising our politicians, I'm afraid of. Interestingly, this is a recent paper in Nature, well, a preview of a paper that is in peer review, but also showing, according of the relaxation, I would say, or the reopening of a number of measures like the restaurants, the fitness centers, the cafes, hotels, how much that will influence or impact additional infections compared to no reopening. And of course, that will tremendously impact probably all our way of living in the coming months and perhaps also in 2021. So relative measures will be possible, but probably not the normal way of living that we were used to so far. So defining the exit strategy, a number of countries now after the second wave or in the middle of the second wave are already looking at how are we going to go out and to relax in the near future. Ireland is taken as an example by some European countries because of the use of their barometer, where according to a certain level of endemicity, certain measures are possible or not possible. And so the aim, of course, is to move as quickly as possible to the left of this barometer so that you can open a number of or relax a number of measures, offer a lot of new freedom to the citizens, but still try to keep the epidemic under control. So it's a kind of continuous balance or equilibrium between measures on the one hand and, of course, control of the infectious disease through contact tracing, source tracing, testing policy that we have all experienced so far. What will be the new normal? Travel limitations, as I said, systemic screening and testing. Some countries are doing this, sometimes on a country broad level. We also realize that we need to absorb the consequences of the COVID-19 priority at all levels, daily activities on the one hand. But as was raised yesterday during the advisory board, we also experience this daily in our research activities, whether it is PCR material, lab material, PCR substances that you need, the non-COVID research activities that are delayed. I can talk for myself that other vaccine trials are very often postponed, on hold, and we give priority to phase 1 up to phase 3 COVID vaccine trials. So which means that all the rest has to wait. Also the threshold at the level of exchange of personnel, of students, so the international exchange of scientists is no longer evident. There are a lot of delays in medical and lab activities, as we all know, screening programs, and we will hear more about that in the coming 48 hours, but also on therapy in general, surgical interventions. We have very sad stories of people in all countries, I think, who experience this delay in medical activities. What's also interesting, and I'm very thankful to Gret, who helped me to put a number of slides together, is to look at what does it mean for universal immunization programs at large. I know some of the speakers will go into the details for the HPV immunization programs, but in general, what we see is that there is a risk of disruption of the childhood immunization programs, the uptake, sometimes the interruption of the universal childhood programs, in a delay in infant and school immunization, delay in outbreak response activities, in particular in low and middle income countries, and we think of polio and measles. We hear stories of caregivers that are reluctant to still see, I would say, children and parents to offer the vaccine, parents who are afraid to go to the well baby clinics, and sometimes facilities that are closed in particular during the lockdown period in a country. Just a few examples briefly, but the slides are available so you can go into the details later on. But this shows indeed the impact in the US when the national emergency was declared in March, the impact on the non-influenza vaccines and on the measles containing vaccines in terms of changes in doses that are ordered. So not really in immunization rate, but in doses ordered. Similarly, from another study also published in the Morbidity and Mortality Weekly Report, the impact on HPV, so on the school immunization program in some US states. On the contrary, and that's also interesting, some countries are very flexible. This is an impact on routine childhood vaccination in the UK, in particular for the hexavalent vaccine and the measles-containing vaccine, where we can see that some measures had an impact in 2020 on the coverage, but how quickly a country is able also to recover and to try to remediate. So that's also very important, showing the flexibility of a country, or at least of an immunization program in a country. Delay of vaccines, for instance, in Saudi Arabia, according to the age of administration, varying between, I would say, 5 and 17% or even more. That's also quite interesting, but I show this because it illustrates also the reasons for the delay. So the fear to get infected by COVID-19, the fact that people have no time because they are so busy with other activities during this pandemic, because everything has been prioritized in a different way. or not possible to make an appointment. So parents, and you see that also from this slide, expect a lot of flexibility from the immunization program, whereas they were used to go to a well baby clinic. Now it looks like they expect almost home visits for diminishing, I would say, the risk of transmission. So that's very interesting and important to understand. What we finally, and I will just try to end with a number of slides with different bullets, what we also discussed yesterday during the advisory board. So we know that health budgets and personnel, manpower, are now very often reoriented to non-vaccine activities or to COVID-19 activities, which are very often not vaccine related or not, I would say, the routine therapeutic or surgical activities. So we see also a shift from prevention to treatment and care because there is no other choice. I can tell you, just to find personnel to conduct a large phase 3 trial in Belgium is a real issue, because we don't find enough doctors and nurses to do the trial, because they are all absorbed by the hospitals and by the emergency department, by the intensive care department. Increase in poverty with impact on health and prevention, that has also been shown and modeled. As I said, parents expect extreme flexibility from the healthcare system, which in addition puts the healthcare system under pressure. In particular, for a large number of immunization programs, we will need to foresee in catch-up programs, in adapted information, and again, in tremendous flexibility. And I think at the level globally, but also at the country level, there is competition for vaccine budgets in the future if we also want to implement COVID-19 immunization programs. But also at the level of the donors, there is competition with other budgets, and that's also something we need to take into consideration. This just illustrates the impact of COVID-19 on global poverty, where you see the historical trend and then what was forecast before COVID-19 pandemic, and then the baseline forecast showing again an increase in the proportion of people living below the $1.90 a day. Also, UNICEF has a very nice report on vaccine access. I will not go into details, but just show you overall slides that shows a substantial number of countries where the routine immunization is suspended or affected. And we know this will be translated in a large number of vaccine preventable infectious diseases and outbreaks. Also, the campaigns and, as I said, outbreak response activities are sometimes postponed again in a substantial number of countries. And this is all as a consequence of other priorities in these respective countries. For that aim, the WHO has drafted a guide for immunization activities during the COVID-19 pandemic, but also I think in the future we'll really have to take that into consideration. How can we restart, or how can we really look at schedules, catch-up schedules for children in these countries? In addition to the whole discussion how to manage the COVID-19 pandemic in a number of countries, we also see that the trust in the government is decreasing in many countries, and that's also spilling over in the trust in vaccines. And I will not enter into all these details, but it's just to say that this is another component that we need to take into consideration in our communication, in our information that we will have to do regarding the launch of COVID-19 immunization programs, but also we have to really pay attention for these trust elements. So I think I covered most of what is shown here. And how will 2021 look like, to show you my last slide? I think it might be rather similar to 2020. So we hope, of course, to avoid that kind of yo-yo effect of measures going from the one lockdown into the other. by too early relaxation of measures. We will have to see how to prioritize COVID-19 vaccination programs, because this will have clearly consequences in the respective countries. We know that 2021 will probably be a year of transition, with increasing background immunity against COVID-19 through the start of the immunization programs, perhaps also as a consequence of the epidemic itself, although that is not very clear. We don't know how long that immunity will last. But it will be still a year, I think, in reduction of social contacts, where we have to manage that kind of societal disruption with all the consequences on psychological level, but also on medical level, as we discussed earlier. Thank you.